Assalamualaikum and good day. We Group 7A would like to present our ambulatory care clerkship case. Our patient, Mrs. P, is a 55 years old Malay female who is overweight. Her parent had diabetes and hypertension. She has been taking caffeine. Her medical history includes hypertension for 10 years, type 2 diabetes mellitus for 10 years, and hypercholesterolemia for 4 years. Her current medication include metformin hydrochloride 500 mg twice daily, combination irbesartan hydrochlorothiazide 300 mg 12.5 mg once daily, simvastatin 20 mg once daily, and ciprofloxacin 100 mg once
For
daily.
the possible drug-related problem, first is the interaction between irbesartan hydrochlorothiazide and also antidiabetic, which requires dosage adjustment for patients who is on antidiabetic therapy. Second is ciprofloxacin and simvastatin interaction, which may cause rhabdomyolysis. And third is poor adherence to simvastatin, which will increase the risk of coronary heart disease if patient is not adhere to medications. Consuming coconut oil can worsen lipid profile by increased total cholesterol and LDL level. Olive oil, on the other hand, is proven to affect blood pressure, blood glucose, and also lipid profiles. Lastly, fish oil is reported to have hypotensive effects and can decrease TG levels. So, concurrent use of these supplements and medications might give additive effects and further affecting blood pressure, glucose, and lipid levels. For the evidence to support diagnosis, first is diabetes. Age is one of the risk factors because based on National Institute of Diabetes and Digestive and Kidney Disease, person who is 45 years old and older is at risk to develop diabetes. The second risk factor is family history, where metabolic abnormalities might involve in the development of diabetes. Lastly is overweight, where our patient has a BMI of 29. According to CPG Management of Diabetes Mellitus, testing for diabetes should be done for adults with BMI of 23 or more and have one or more risk factors, such as having first-degree relative with diabetes and also hypertensive patients. Next is hypertension. The first risk factor is family history. Since both of her parents have hypertension, she has a 2 to 4-fold higher risk of getting this disease. Second is overweight. Higher BMI is associated with higher blood pressure and development of hypertension. The next risk factor is diabetes mellitus. Previous researchers reported that the incidence of hypertension increases significantly in the presence of diabetes. And lastly is hypercholesterolemia, where this condition is closely related with the mechanism involved in the blood pressure elevation. The last diagnosis is hypercholesterolemia. The first risk factor is obesity. Since our patient is overweight borderline obese, she might be at risk of an increased TG, LDL, and even blood glucose and blood pressure. This will in turn cause increased risk of cardiovascular disease. The next risk factor is type 2 diabetes. Free fatty acid flux secondary to insulin resistance might affect lipid profile, such as increased TG and LDL, while lowering the HDL.
Treatment suggested for the diagnosis. First is type 2 diabetes mellitus. Based on CPG, metformin is preferred as first-line therapy when lifestyle intervention fail to provide adequate glycemic control. In this case, the patient has been on metformin 500 mg twice daily for 10 years. Glycemic control should be assessed by measuring her HbA1c. Failure to achieve the glycemic target will require modification in the treatment, for example, combination with other oral anti-diabetic agents or insulin. Second is hypertension. According to the CPG, combination therapy is considered as first-line therapy in very high-risk stage 1 hypertension and stage 2 hypertension. For patients with diabetes and hypertension, initiate ACE inhibitor in diabetes without proteinuria. Use ARB for ACE inhibitor intolerant patients. Thiazide-like diuretics or calcium channel blocker can be added on when monotherapy is inadequate. Patient is currently on 300 irbesartan and 12.5 mg hydrochlorothiazide once daily. If patient is ACE inhibitor intolerant and BP is under control, combination therapy of ACE inhibitor and thiazide is appropriate for this patient. Third is hypercholesterolemia. In women, statin is the first choice of treatment for LDL-C reduction to reduce risk of cardiovascular disease. In patients aged more than 40 years old, with type 2 diabetes mellitus, moderate intensity statin is indicated. This patient is on simvastatin 20 mg OD and ciprofloxacin 100 mg OD. We suggest to discontinue ciprofloxacin because of the increased risk of myopathy with concurrent use of simvastatin, and evidence from randomized controlled trial do not recommend use of fibrate with statin. We also suggest to increase the dose of simvastatin to 40 mg OD since the patient has high cardiovascular risk. For intervention, suggest lifestyle modification to improve patient's conditions such as diet modification, weight reduction, and regular physical activity. Provide patient education on importance of medication adherence and ways to improve adherence, such as using pill box. Advise patient to discontinue the use of coconut oil as it may worsen lipid profile. Advise patient to monitor her BP and blood glucose regularly as olive oil may increase the effect of antihypertensive and hypoglycemic agents. Fish oil will interact with antihypertensive drug which may lower the BP. Educate patient on symptom, risk and treatment of hypoglycemia. To evaluate the effectiveness of metformin, HbA1c should be performed approximately every 3 months. The typical target is 7%. Self-monitoring of blood glucose by the patient is also desirable. Monitor the long-term complication of diabetes is appropriate. In terms of safety, sign and symptom of hypoglycemia, hyperglycemia and side effect of metformin, for example, vitamin B12 deficiency, should be monitored. To evaluate the effectiveness of irbesartan and hydrochlorothiazide, patient can carry out self-monitoring of blood pressure. The target blood pressure is less than 130/80. In terms of safety, monitor serum creatinine, electrolyte, and BUN. Monitor the side effects of the medication such as headache, dizziness, gastric irritation, and hypotension. Besides that, monitor blood glucose level as hydrochlorothiazide might decrease the effect of anti-diabetic agent. To evaluate the effectiveness of simvastatin, monitor the lipid profile to ensure lipid target can be achieved. Target LDL-C is less than 1.8 micromole per liter. In terms of safety, monitor any changes in muscle effect, for example, muscle weakness and muscle pain. Monitor side effects of simvastatin, for example, dizziness, headache, and abdominal pain. Monitor the blood glucose level as simvastatin may cause hyperglycemia.